Salmonella is a bacterium belonging to the family Enterobacteriaceae. There are two main species, Salmonella bungori and Salmonella enterica, and the latter has 6 subspecies. One of those subspecies is enterica, which has over 2,500 serotypes that can be divided into 2 main groups based on the clinical symptoms they cause, so typhoidal or non-typhoidal. The non-typhoidal group can infect humans and animals and cause a variety of disease states, but the most common serotype, Salmonella enteritis, causes intestinal inflammation, which is also called gastroenteritis, or commonly called food poisoning. Now, in general, Salmonella are encapsulated gram-negative rod bacteria, meaning they have a polysaccharide layer outside the cell envelope, and they look like little red or pink sticks on a gram stain. They're facultative intracellular pathogens, meaning they can live both outside or inside of its host cells. And they have flagella, making them motile, but they don't form spores. They're also facultative anaerobes, so they can undergo respiratory and fermentative metabolism. And they can ferment glucose but not lactose. They're oxidase negative and produce hydrogen sulfide gas. And while a variety of media can be used to selectively identify Salmonella, among them is triple sugar ion agar, which produces a black precipitate when hydrogen sulfide is produced. Now, once Salmonella is ingested and reaches the distal ileum of the small intestine, it tends to target the epithelial layer of the mucosal lining, where it uses surface appendages to adhere to microfold cells, or M cells. And these M cells eat, or phagocytose, the bacteria from the intestinal lumen and spit it out into the underlying Peyer's patches, a type of mucosal immune tissue that extends into the submucosa. When encountering non-typhoidal Salmonella, the immune system responds strongly by releasing pro-inflammatory cytokines that recruit additional immune cells, particularly neutrophils. This causes inflammation of the small intestines and the colon, called enterocolitis. Responding immune cells can also damage the mucosa as they travel to the site of infection. This can cause ulcers and gastrointestinal tract dysfunction that leads to an efflux of water and electrolytes into the intestinal lumen, which causes diarrhea. Now, usually, the infection is uncomplicated and limited to the mucosa, where it's often destroyed by the local immune cells. But in some cases, the infection can become invasive, gaining access to nearby blood vessels, causing bacteremia. From the bloodstream, the bacteria can spread to other organs like the brain, bones, liver, or spleen. Now, reservoirs for non-typhoidal Salmonella include infected humans and animals, particularly birds, reptiles, mammals, and amphibians. So, transmission can be fecal to oral and foodborne through consumption of contaminated raw or undercooked animal products, especially poultry, meat, and eggs, or unpasteurized milk or milk products. Transmission can also occur through any contaminated consumable, like water, fruits and vegetables, and even peanut butter. Finally, the infection can also spread through direct contact with infected animals, if contaminated hands then reach the mouth. Now, because Salmonella is sensitive to gastric acid, a large inoculum, meaning more than 100,000 microorganisms, is needed to cause an infection. But certain factors, like being a young child, an older adult, having low gastric acidity, or being immunocompromised, can cause an elevated risk of infection and development of invasive, complex cases. Now, sometimes symptoms can be absent, even if a host is infected and a carrier capable of spreading non-typhoidal Salmonella. When symptoms do occur, they start after 24 to 48 hours, and they're pretty typical for food poisoning: watery diarrhea, which may be bloody, abdominal cramps, nausea and vomiting, headache, chills, and a low-grade fever, which typically resolves within 2 days. Dehydration may also occur if fluid loss from diarrhea has not been replenished. A definitive diagnosis can be made with a stool culture on selective media. In invasive infections, additional cultures, like blood and bone marrow aspirate cultures, may be necessary. Treatment involves managing symptoms, particularly fluid and electrolyte replenishment for diarrhea, suppressing nausea, and alleviating pain. Antibiotics are typically not indicated for uncomplicated infections, since infections tend to be self-limiting, and antibiotics can prolong a carrier state or even cause relapse. However, antibiotics are usually given in invasive infections, especially in complicated cases, like in immunocompromised individuals, and antibiotic selection is made based on sensitivity of the particular infecting strain. Finally, an important part of treatment is practicing good hygiene and sanitation, including proper food and hand washing, and thoroughly cooking raw foods. Alright, as a quick recap, Salmonella is a rod-shaped, gram-negative bacteria of the Enterobacteriaceae family. After ingestion, Salmonella tends to infect M cells of the small intestine epithelial mucosa, which transfer the bacteria to the underlying Peyer's patches. Serotypes that are non-typhoidal elicit a strong pro-inflammatory response, which causes inflammation of the small intestine and colon. Infections are usually foodborne from contaminated sources or from interactions with animal reservoirs, and cause the hallmark symptoms of food poisoning, including abdominal cramps, vomiting, headaches, fever, and diarrhea. Diagnosis can be made with a stool culture, and treatment is typically fluid and electrolyte replenishment, especially in uncomplicated or non-invasive cases. But in complicated, invasive infections, antibiotic therapy may be necessary. Salmonella is a bacterium belonging to the family Enterobacteriaceae. There are two main species, Salmonella bungori and Salmonella enterica, which itself has 6 subspecies. One of the subspecies is enterica, which has over 2,500 serotypes that can be divided into 2 main groups based on the clinical symptoms they cause, typhoidal or non-typhoidal Salmonella. The typhoidal group, which includes serotype Salmonella typhi, or S. typhi, specifically infects humans and causes enteric fever, which is more commonly called typhoid fever. If left untreated, it can be fatal, and throughout history has been the cause of death of aviator and engineer Wilbur Wright, one of the Wright brothers, Dr. Hashimoto, who was the first to describe Hashimoto's thyroiditis, and several people in New York City infected by Typhoid Mary, in the first documented asymptomatic carrier of the disease in the United States. Generally, Salmonella are encapsulated gram-negative rod bacteria, meaning they have a polysaccharide layer outside the cell envelope and look like little red or pink sticks on a gram stain. They're facultative intracellular pathogens, meaning they can live both outside or inside of its host cells. They have flagella, making them motile, but don't form spores. They're also facultative anaerobes, so they can undergo respiratory and fermentative metabolism. And they can ferment glucose, but not lactose. They're oxidase negative and produce hydrogen sulfide gas. And while a variety of media can be used to selectively identify Salmonella, among them is triple sugar iron agar, which produces a black precipitate when hydrogen sulfide is produced. Now, once Salmonella is ingested and reaches the distal ileum of the small intestine, it targets the epithelial layer of the mucosal lining. Here, it uses surface appendages to adhere to the microfold cells, or M cells, and these M cells eat, or phagocytose, the bacteria from the intestinal lumen and spit it out into the underlying Peyer's patches, a type of mucosal immune tissue that extends into the submucosa. S. typhi has a VI capsular polysaccharide antigen virulence factor, which helps protect the bacteria from being tagged with antibodies that signal leukocytes like neutrophils to come in and phagocytose the bacteria. On top of that, neutrophil recruitment is also suppressed. Now, on the other hand, the recruitment of monocytes and macrophages is induced, making them the primary cells that respond to the infection. And as they're recruited to the infection site, they cause hypertrophy and necrosis of the surrounding tissues, which can damage the epithelial lining and potentially lead to ileal perforation, consequently, a secondary infection of the peritoneum. Now, aside from that, macrophages also phagocytose S. typhi, so the bacteria is slowly engulfed by the cell membrane, which invaginates to form a sac on its inner side. The sac then separates from the actual cell membrane, forming what's referred to as a salmonella-containing vacuole. Normally, the vacuole would fuse with the host cell's lysosomes, which are organelles filled with digestive enzymes that destroy the bacteria. But S. typhi uses needle-like protein appendage, called a type 3 secretion system, to inject a variety of effector proteins across the vacuole membrane and into the host cell's cytoplasm. This leads to a remodeling of the vacuole that prevents fusion with the lysosome, so S. typhi survives and replicates within the vacuole. Now, while this is all happening, S. typhi is using the host macrophage to hitch a ride to the nearby lymphatic vessels that drain into the local mesenteric lymph nodes. Once there, the macrophage can continue to flow through the thoracic duct and into systemic lymphatic circulation, where they can enter reticuloendothelial tissues in the liver, spleen, bone marrow, gallbladder, and additional lymph nodes. At about this point, S. typhi can induce macrophage apoptosis, or cell death, so the bacteria is released into the bloodstream, called bacteremia. Bacteremia can progress to sepsis, an acutely life-threatening condition characterized by systemic vasodilation and hypoperfusion of vital organs, which means the organs aren't getting enough nutrients and oxygen-rich blood. Another complication can arise in individuals with spleen issues, because the spleen plays an important role in immunity against encapsulated bacteria. This includes people who have undergone a splenectomy or spleen removal, or those with sickle cell disease who have functional asplenia. In these individuals, S. typhi can cause osteomyelitis, which is an acute infection of the bones. On the other hand, some people can become chronically infected with S. typhi, and that means they're carriers for the bacteria for decades or a lifetime, even after symptoms have resolved. In these cases, S. typhi typically remains in the gallbladder and is periodically swept along with bile through the bile duct to the intestines, where it can be excreted in feces. Now, S. typhi is uniquely adapted and restricted to only infect humans, who are also the only known reservoir, and its route of transmission is fecal to oral, even if the feces come from a currently asymptomatic host. So, transmission is usually linked to any contact between contaminated hands or objects and the mouth, and also to poor sanitation and poor hygiene that leads to consuming contaminated water or food, especially if it's prepared with unwashed hands. It also seems to be particularly endemic to Asia, Africa, Latin America, and the Caribbean. Finally, S. typhi is sensitive to gastric acids, so half the time it takes a large inoculum of around 100,000 microorganisms to cause an infection. Now, symptoms of typhoid fever first appear about 1 to 2 weeks after initial infection and can take 4 to 6 weeks to resolve. Typically, there's a high, sustained fever, abdominal pain, constipation followed by diarrhea, and rose or salmon-colored spots on the chest and abdomen. Hepatomegaly and splenomegaly can also occur as the infection spreads. Dehydration, weakness, headaches, and an overall cloudy or confused mental state can occur, especially in advanced cases. Diagnosis can be confirmed with cultures from blood, intestinal secretions like vomit or duodenal aspirate, or stool cultures, which can identify S. typhi, particularly in the first week of infection. For asymptomatic carriers, bile cultures are the most effective diagnostic tool because the bacteria can be absent from stool. Treatment involves managing symptoms, particularly fluid and electrolyte replenishment for diarrhea, and non-steroidal anti-inflammatory drugs for pain and fever. Commonly, broad-spectrum antibiotics are used, like fluoroquinolones or cephalosporins, like ceftriaxone, even though antibiotics can prolong the excretion of bacteria in feces. For carriers, a combination of antibiotic therapy with fluoroquinolones and surgical removal of the gallbladder is the most effective form of treatment. Finally, an important part of treatment is practicing good hygiene and sanitation to limit the spread of uninfected individuals. Prophylaxis is available in the form of an inactivated intramuscular vaccine containing the VI capsular polysaccharide, or a live oral vaccine. Alright, as a quick recap, Salmonella is a rod-shaped, gram-negative bacteria of the Enterobacteriaceae family. After ingestion, Salmonella tends to infect M cells of the small intestine epithelial mucosa, which transfer the bacteria to the underlying Peyer's patches. Serotypes that are typhoidal evade and dampen the immune system, and use host macrophages to systematically spread through the entire lymphatic system and bloodstream. Symptoms include a high fever with constipation, followed by diarrhea, salmon-colored spots on the abdomen, and abdominal pain. A carrier state exists when the bacterium colonizes the gallbladders of people with the disease, so they can continue to excrete bacteria in their feces. Treatment can include a ceftriaxone or fluoroquinolone, but antibiotics can prolong fecal excretion of the pathogen. Vaccines exist, with an oral live attenuated vaccine and an intramuscular vaccine containing VI capsular polysaccharide.
Shigella is a gram-negative bacterium that belongs to the Enterobacteriaceae family. There are 4 species of Shigella: Shigella dysenteriae, Shigella flexneri, Shigella boydii, and Shigella sonnei, and each has its own serotypes. In humans, these species can all cause shigellosis, which is a contagious infection of the intestines, particularly the colon. And shigellosis can progress to dysentery, which is when the infection causes inflammation of the colon, resulting in severe abdominal pain and diarrhea. Now, Shigella is a gram-negative, rod-shaped bacterium, meaning it looks like a little red or pink stick on a gram stain. And it's a facultative anaerobe, so it can survive with or without oxygen in the environment. It has no flagellum, making it non-motile, and it does not form spores. It's also a non-lactose fermenter, so it doesn't ferment lactose. And it's urease and oxidase negative, meaning it does not produce these enzymes. Finally, it doesn't produce hydrogen sulfide gas either, and this can be used to selectively identify Shigella on special culture mediums like MacConkey agar. On this medium, Shigella mostly forms white, non-lactose fermenting, non-hydrogen sulfide producing colonies. Now, once Shigella is ingested, it multiplies in the small intestine, and then passes into the colon. There, it targets the epithelial layer of the mucosal lining where it infects colonic enterocytes and microfold cells, or M cells. And these M cells phagocytose, which means they eat the bacteria from the intestinal lumen, and then spit it out into the underlying mucosa-associated lymphoid tissues, or MALTs. MALTs are a type of mucosal immune tissue that extends into the submucosa, and contains plenty of immune cells like macrophages. The macrophages gobble up Shigella to neutralize the pathogen, but the bacterium induces apoptosis, or programmed cell death, in the macrophage. Now, when a macrophage dies, it releases a variety of cytokines, including interleukin-1 beta, which activates an intense inflammatory process that recruits additional immune cells to wage war at the site of the infection. And this results in the death of epithelial cells, which damages the colonic mucosa, resulting in ulcerations and abscesses. All the damage and migration of immune cells, particularly polymorphonuclear leukocytes, through the epithelium disrupts the cellular junctions between neighboring epithelial cells, allowing Shigella from the intestinal lumen to enter enterocytes through the lateral sides of the cell. And actually, that's not the only way Shigella can infect enterocytes after the initial infection. After Shigella kills the macrophage and is released into the immune tissue under the epithelium, it can access and infect colonic enterocytes from their basal side. Shigella uses its type 3 secretory system, which acts almost like a syringe, to puncture and inject proteins into the enterocyte and makes the enterocytes phagocytose Shigella. So that means Shigella is slowly engulfed by the cell membrane, forming a membrane-bound compartment that eventually pinches off from the cell membrane and ends up inside the cell, where it's called a phagosome. Then Shigella can use a number of effector proteins, which lyse the phagosome and release Shigella into the cytoplasm. In the cytoplasm, effector proteins also induce Shigella's actin-based motility. This starts by recruiting the host cell's small actin filaments to one end of the bacteria, And as more and more actin filaments get recruited and polymerized behind the bacteria's end pole, that propels the bacteria forward, like a rocket. That helps Shigella blast through the lateral sides of both the host enterocyte and after the neighboring enterocyte, further spreading the infection. Finally, one particular species of Shigella, Shigella dysenteriae serotype 1, also produces shigatoxin. Shigatoxin, similar to the Shiga-like toxin-producing pathotype of E. coli, is an AB toxin, so it has two main subunits, A and B, that are joined by a disulfide bond. Each subunit plays a specific role in the invasion and destruction of a host cell. The B subunit helps bind the toxin to the host cell's membrane, where the toxin is ultimately engulfed into a phagosome. Within the host cell's cytoplasm, the inside of the phagosome becomes more acidic, and as a consequence, the disulfide bond holding the two subunits together becomes weak and eventually breaks, separating the subunits. At this point, the A subunit can then diffuse through the phagosome membrane into the cytoplasm, where it targets the ribosomes. In eukaryotic cells, ribosomes are made of two main subunits. The larger of the two is the 60S subunit, and it contains a 28S rRNA protein that's important for the initiation of polypeptide synthesis. The shigatoxin A subunit cleaves 28S rRNA, and the end result is an arrest of protein synthesis, followed by cell death. If shigatoxin reaches the endothelial cells that line the mucosal blood vessels, it can damage them, which allows the toxin to enter the bloodstream, causing complications like hemolytic uremic syndrome. So that means from the bloodstream, the toxin can get to the kidneys and bind to the endothelial cells lining the glomerulus, making them die by apoptosis. Consequently, a dead endothelial cell leaves a gap in the capillary wall, and as more gaps keep forming, it results in holes big enough to allow large molecules like proteins to start leaking out of the capillaries, resulting in proteinuria. The destruction of endothelial cells triggers an inflammatory process in which inflammatory molecules like cytokines and chemokines are released. Cytokines and chemokines activate blood platelets and initiate the clot formation. As these platelets are used to form these clots, their number in the blood decreases, resulting in low platelets or thrombocytopenia. Also, these clots can be big enough to obstruct small arterioles. So as red blood cells are forced to pass through obstructed microvessels, they can get sliced into fragments called schistocytes, in a process known as microangiopathic hemolysis. So as more red blood cells get destroyed in the process, their number reduces, which can cause anemia. Alternatively, if clots obstruct too many arterioles, organs that depend on high blood flow, like the kidney, might lack blood and die by ischemia. Now, an ischemic kidney is unable to filter blood. This is how too much of metabolic waste, like urea, start accumulating in the blood, leading to uremia. Then HUS is a combination of hemolytic anemia, when red blood cells are being overly destroyed, kidney failure due to destroyed glomerular cells that results in uremia or high levels of blood urea, and thrombocytopenia, meaning low platelets. Alright, now Shigella can survive the acidic stomach pH, making it extremely virulent, where as few as 10 bacteria can cause an infection. And Shigella is typically transmitted through the fecal-oral route, so this can include consuming contaminated water or food, particularly if prepared with unwashed hands, flies that carry stool particles from one place to food, as well as contact with contaminated objects or hands that reach the mouth. Sometimes Shigella can be transmitted through forms of sexual contact. Typical symptoms of shigellosis are related to the resulting dysentery, and last for approximately 7 days. They include severe abdominal and rectal cramping and pain, high fever, vomiting, loss of appetite, fecal incontinence, and watery mucus-like diarrhea which can contain blood or pus. In extreme cases, particularly in children, tonic-clonic seizures might happen. That's when consciousness is lost and involuntary phases of muscle activity progress from a rigid or tonic phase to a clonic phase of rhythmic contractions and relaxations. And even sepsis can happen, but most often in neonates, malnourished children, and people with a Shigella dysenteriae serotype 1 infection. And finally, reactive arthritis, also called Reiter syndrome, can rarely occur in the weeks following an infection, and it usually affects the knee joints, causing pain and swelling. A definitive diagnosis of shigellosis can be made with a fecal sample cultured on selective media like McConkey agar, were again white, non-lactose fermenting, non-hydrogen sulfide producing colonies of Shigella form. Stool stains with methylene blue might also show polymorphonuclear leukocytes. Polymerase chain reaction, or PCR testing, which directly identifies Shigella DNA, can also be done. Treatment of shigellosis involves fluid and electrolyte replenishment and, commonly, the use of antibiotics, including beta-lactams, both penicillins and cephalosporins, macrolides, and quinolones. Finally, an infected person can be a carrier for infection up to 4 weeks after onset of symptoms. So an important part of treatment is practicing good hygiene and sanitation to limit the spread to uninfected individuals. Alright, as a quick recap. Shigellosis is a contagious infection caused by the bacteria Shigella that targets M cells and enterocytes in the colonic mucosa. Shigella causes destruction and inflammation of the epithelium that can lead to dysentery with hallmark symptoms like severe abdominal and rectal cramping and pain, a fever, and watery diarrhea with mucus with or without blood or pus. Its route of transmission is fecal to oral, mainly through fingers, food, flies, and feces. It's diagnosed with a fecal sample, and treatment centers around fluid and electrolyte replenishment, and antibiotics.